Hi guys, today's lecture about tuberculous lymphadenitis. Mostly it's about cervical lymphadenitis by tubercular infection. It is also called scrofula. Tubercular lymphadenitis is a chronic specific granulomatous inflammation of lymph node with caseation necrosis caused by Mycobacterium tuberculosis or Mycobacterium bovis. The characteristic morphological element is the tuberculous granuloma is caseating tuberculosis necrosis. This is consist of giant cell multinucleate cells and Langerhans cells, which is surrounded by epithelioid cells and T cell lymphocytes and some fibroblasts. The granulomatous tuberculosis eventually develop central caseous necrosis and tend to become confluent, replacing the lymphoid tissue, which leading to necrosis and pus formation. As you can say, stages of tuberculous lymphadenitis, there are 5 stages. First stage, there is lymphadenitis. It means there is infection of cervical nodes, which leading inflammation and surrounding lymphocyte formation. After that, there will be second stage of periadenitis. It means the inflammation of surrounding capsule or surrounding tissue by tubercular infection. After that, third stage will be called abscess. There will be abscess formation at coalescence or multiple site in the neck, which ultimately leading to collar stud abscess. So in this stage, there is gross abscess formation in the neck. Ultimately, this abscess collection leading to discharge, leading to sinus formation. So there are 5 stages of tubercular lymphadenitis. Lymphadenitis first stage, second stage will be periadenitis, third stage will be cold abscess, fourth stage will be collar stud abscess, and fifth stage will be sinus formation. The scrofula initially referred to a lymphadenitis of central lymph nodes associated with tuberculosis as well as non-tuberculosis atypical mycobacteria. 90% of the scrofula in adult caused by Mycobacterium tuberculosis, most often in immunocompromised cases. So this is MCQ, 95% caused by Mycobacterium tuberculosis. In immunocompetent children, scrofula is often caused by atypical Mycobacterium, Mycobacterium scrofulaceum, and other non-tuberculous Mycobacterium only having 8% due to tuberculosis. The resurgence of tuberculosis is mainly due to HIV, which is immunocompromised stage, leading to resurgence of tuberculosis in most of the countries. Clinically, the chronic painless mass, slow growing, may have cold abscess. There is no warmth or color or any tenderness or pain in the neck. So this is characteristic of tuberculosis. There is chronic painless, slow growing mass in the neck. In non-tubercular infection, do not show other notable constitutional symptom, but scrofula caused by TB is usually accompanied by fever, chills, malaise, weight loss in about 43% of the cases. So diagnosis of tuberculosis can be done by FNAC or excision biopsy according to the case individually decided by surgeon. Gram staining or acid-fast bacilli or Gill-Nielsen staining can be done of the tissue. Culture using specific growth can be best for the diagnosis and can be seen. And gene expert nowadays done for DNA study for resistance of the tuberculosis. The treatment of tuberculosis with tuberculous scrofula, iodine excision followed by AKT4 should be given for 6 to 9 months. Non-tuberculous surgery is single antibiotic with 90% result within 7 days. IND and single antibiotic therapy should be given for non-tubercular mycobacterial infection. Some special points about Mycobacterium tuberculosis: obligate aerobe, non-spore forming, slender rod, transmission by aerosol. Non-tubercular differ from Mycobacterium tuberculosis in two respects. One is person to person transmission does not occur in NTM. NTM species are ubiquitous in nature and not necessarily pathogenic or acquainted with the disease. AKT4 kit should be given for it is also called anti-cox therapy, containing 1 tablet ethambutol hydrochloride 800 mg plus isoniazid 300 mg, containing 2 tablets of pyrazinamide 750 mg and 1 capsule of rifampicin 450 mg. Main side effect of ethambutol will be retrobulbar optic neuritis. This is MCQ commonly asked in many exams. Isoniazid, most common complication will be hepatocellular jaundice or peripheral neuropathy in bilateral feet. This is common side effects of the isoniazid. Pyrazinamide most commonly leading to jaundice and hyperuricemia, that is gout because of pyrazinamide. Rifampicin, which is most common side effect, jaundice and flu-like symptom, decreased platelet count or commonly having orange color urine or red color urine, which sometimes leading suspicious of blood in urine in some patients. So you have to counsel patient properly. Orange color urine because of rifampicin. This is also MCQ. Sometimes rashes because of rifampicin. The most common site of mycobacterial infection in the neck is the anterior cervical, superior cervical lymph node. You can say jugulo-omohyoid type second nodes are most commonly, followed by posterior cervical. Level 2 are most common, then posterior cervical level 5 is second most common, middle cervical level 3rd, that is second, this is most fifth, second followed by fifth, then third, then fourth. These are the common node involvement, and submental region may be involved in. These are the first nodes. These supraclavicular may be fourth or fifth. So these are the common nodes. Anterior superior cervical node, most common MCQ ask, jugulo-omohyoid. Then posterior cervical, then middle cervical, then supraclavicular, then submental nodes are more common. Atypical mycobacterium are not frequently found in the preauricular region, tend to occur unilaterally, whereas Mycobacterium tuberculosis is more diffuse and frequently bilateral in the neck. The overlying skin is frequently discolored with the atypical mycobacterial infection, whereas in tuberculosis it is painless or no any discoloration in the skin of the neck. So this is about tuberculosis, or you can say scrofula of the neck. Thank you so much.